So we welcome our today's speaker, Dr. Dilip Iyengar, sir, very well-known senior consultant medical oncologist, DHS Multispeciality Hospital, Ahmedabad. Welcome, sir.
Thank you, Rahul bhai.
Sir, breast cancer is the most common cancer among women worldwide, and it's increasing seen in younger age groups too. So I invite Dr. Dilip sir to talk on breast cancer in current age and times. Please, sir.
Thank you so much, Rahul bhai. Namaste to all of you from IMA. And today being the the COVID Martyrs Day, it is my honor and privilege to speak on such a day. We remember that with all humbleness. And I would like to start my talk with this. So this is a talk in brief about breast cancer. And first, I would like to start with what are the types of breast cancer, what are the patterns of breast cancer. You have what is known as invasive ductal carcinoma, which constitutes the majority of the cases of breast cancer, 70 to 80% of cases. Then you have invasive lobular carcinoma. You have triple negative breast cancer, which is one of the riskiest forms of breast cancer. You have in situ breast cancer, which can be either ductal or lobular. You also have inflammatory breast cancer, which is very rapid fire breast cancer. You have male breast cancer and you have pregnancy with breast cancer. So the first we look at how to detect breast cancer. Detection starts with history. You have usually a painless lump. This is the problem most of the time. Patients expect that they should have pain, or they should have some redness, or they should have some fever. But unfortunately, there is usually no pain. It is usually a painless lump with some puckering of the skin many a times. So most of the times it is missed in the early stage, especially in our country. Sometimes you can also have discharge from the nipple, which can also be blood stained. The other thing to take from history is family history in a first degree relative, either the mother, daughter, sister. And the second thing is you do a mammosonography. Even if it comes to a general practitioner and the patient complains of a lump in the breast, the first thing that should be done is a mammosonography, preferably at a place where there is a low dose mammogram done. So that will help a lot in finding out whether the pattern on the mammography, which is termed as BIRADS, will tell whether this is highly suggestive of breast cancer or not suggestive of, or less suggestive of breast cancer, more benign. Sonography will also give rise to confirmation of the same. Currently, MRI breast is a very, very sensitive way of finding out whether there is breast cancer possible and if there is a high chance of having a breast cancer. Nowadays, with everybody having YouTube, it is to be encouraged for all the women to check how to do a breast self-examination on videos are available easily on the YouTube. They can check themselves, and once in a month or once in 2 months, if there is a family history. If there is no family history, then once in 4 to 6 months will be sufficient. It should be done in front of a mirror after a bath, inside the bathroom if possible. If needed, this patient, if there is a lump which is highly suspicious, then a biopsy can be done, which is usually in the form of a true cut biopsy. Sorry. These days, we don't recommend a fine needle aspiration because the amount of tissue available is very little for a proper histopathology and immunochemistry. So after this, the histopathology and the immunochemistry should be done. So let us understand the disease. In the lowest form is the in situ disease. In situ disease, there is no invasive component seen on biopsy and surgery. And the hormone receptor studies should be done to find determine the further treatment. Same for the ductal, same for lobular. You have to understand that the ductal carcinoma arises from the ductal lining of the breast. This can be hormone receptor positive or negative and can have HER2, immunological target of HER2 positive or negative. And the invasive lobular carcinoma, the lobular carcinoma arises from the breast glandular tissue, which constitutes of 5 to 15% of all the breast malignancies. These are usually slower growing tumors. Majority are hormonal receptor positive, but the response to chemotherapy in these are poorer. So they are more responsive to hormonal therapy. This should be kept in mind. Triple negative breast cancer is a very resistant form of breast cancer and it consists of 10 to 15% of patients. Hormonal receptors are negative in this. HER2 receptor is also negative. This is higher risk, as I said, and younger patients with BRCA mutation is positive more commonly. So once we come to the diagnosis of a breast cancer, then we should do investigations. What are the investigations possible? First thing is blood investigations. In blood investigation, CBC, CEA, CA 15.3, these are the biomarkers for cancer. And other blood tests like liver, kidney function tests should be done. Radiologically, sonomammography, as we already told, and also the MRI of the breast. And if it is proven to be positive, then a PET CT scan or a PET MRI scan is available and as needed. And an MRI brain, if PET CT scan is done, MRI brain in clinically indicated patients should be done because PET CT scan will not cover the brain properly. Tissue diagnosis will require a histopathological examination and immunohistochemistry with hormone receptor study, which is ERPR, estrogen receptor, progesterone receptor, and a HER2 receptor. If HER2 receptor is 2+, then you have to do a FISH study, fluorescence in situ hybridization, FISH study, if it is in doubt. Mutation studies, especially BRCA1 and 2, have to be done, and PDL1 also can be done. Now, when we have a small primary with one or few lymph nodes and PET CT, see, this is called as a breast cancer disease, in which case we will you will have to consider in younger patients and cosmesis conscious patients, you'll have to consider a breast conservation surgery. But I'm so sorry. This must be followed up with radiation. Chemotherapy should be given to all patients which are stage 2 onwards who are fit to receive it, and hormonal therapy positive and HER2 positive, then tamoxifen, letrozole, and anastrozole, exemestane, fulvestrant are the hormonal agents available, and these can be given, and trastuzumab is also to be given if HER2 is positive. Sorry. Ovarian suppression for preservation can be considered in appropriate patients. Over-storing and preserving options should be and can be offered to suitable patients who desire to have families in the future. Neoadjuvant systemic therapy, that is systemic chemotherapy or immunotherapy before doing surgery, that is known as neoadjuvant systemic therapy. This can be considered in select cases to decrease the size and the spread of the disease before loco-regional treatment. What is loco-regional treatment? Loco-regional treatment is surgery and radiation. So before that, chemotherapy or immunotherapy can be given. Pertuzumab and trastuzumab combination can also be tried as neoadjuvant therapy. Later strategies. These are for larger primary disease. Sorry. Thank you. Or disease with more nodes, they will definitely require neoadjuvant therapy and immunotherapy. This is to reduce the size so that it becomes more amenable to surgery and easy to remove or easy to treat with the radiation as well. There are many different regimens available. I will not go into the detail because there are certain things which are best left for us poor oncophysicians. The chemotherapeutic drugs which can be used in combinations are doxorubicin, epirubicin, docetaxel, paclitaxel, cyclophosphamide, eribulin, carboplatin, capecitabine, and many other drugs. Other agents which are used are trastuzumab, pertuzumab in HER2 positive patients, and in PDL1 positive patients, you can even use pembrolizumab. This is now being used in multiple patients as well. Ribociclib and palbociclib can be used in triple positive patients in combination with hormonal agents. And abemaciclib is a new drug which is also being used in such a manner. Adotrastuzumab emtansine, trastuzumab deruxtecan. Trastuzumab deruxtecan can be used even in HER2 1 plus patients or low HER2 positive patients. And in BRCA positive patients, olaparib also can be used. This listing is just to ensure that you have an exposure to the names of the drugs, have an idea of which drugs can be used, so that when they are used, you are not caught unawares in your patient. You look at triple negative disease now. This arises from the basal cells. These are high-risk patients. Systemic chemotherapy is almost a must in most of them. In systemic chemotherapy, platinum-based agents are used in these, and pembrolizumab is also used in combination. Olaparib, if the germ cell BRCA is positive, then we can use olaparib. Sacituzumab govitecan and datopotamab deruxtecan, these are all tongue twisters. These can be used and are being used. Selpercatinib and dostarlimab also can be used. But primarily, you should remember, the negative disease is a very bad disease to have, and it has a very high recurrence rate even after quite some time of the disease being gone. Male breast disease, this is more advanced at presentation usually, because there is not much of soft tissue available in the breast region for males. This is more aggressive. All of them mandate chemotherapy as well. The treatment is as for regular breast cancer, but must be considered more aggressive. Now we come to a different thing. What is the venous axis? See, I'm talking to an audience which is not primarily oncological. So this is very important. If the patient is affording and willing, it is then best to put in a chemo port, because you'll have 4 to 6 cycles, and then followed by sometimes trastuzumab, which can go on for 12 cycles or even 18. So many times, every time taking the vein, and that too only one hand will be available, the other operated side hand will not be available. So it is best to put in a chemo port. But then chemo port is expensive, and it will also require a trained nurse to administer. Not every Tom, Dick and Harry nurse can use a chemo port. So if such a thing is possible, then it is best to put in a chemo port. If the patient is urban and willing to take care but not affording a chemo port, then a PICC, peripherally inserted central catheter, can be inserted and maintained. Otherwise, we have to take a good secure line each time, which is not on the, as I said, not on the side which has been operated. And special care must be taken to avoid any extravasation of the chemotherapeutic agent. It has to be hammered into the nursing caregiver that no pushing of the fluid should be done ever, because if even the slightest amount extravasates, it will cause severe injuries, and then a plastic surgeon will require to be called in. Stage 4 disease. Most important in any patient is to do a PET scan before planning surgery. Because this will obviate the missing out of any early metastatic disease. We had quite a few patients with my surgical colleagues when it seems like as if it is an early disease in the breast, but when a PET was done, a small nodule was seen elsewhere, which converted it into a stage 4, and so the approach turned different. So please never be in a hurry to operate before complete workup. Stage 4 disease requires a palliative approach, not a curative approach necessarily. In future, if everything turns out well, and if it is a oligometastatic disease, that is a low volume metastasis, and if that disappears in the future treatment, then we can think of a curative approach at some time in the future, but not in most of the patients. So patients' expectations and the relatives' expectations have to be tempered with realistic predictions and expectations. How to monitor the progression? See, first you have to see the worsening of the symptoms. Is the patient having increased pain? Is the dyspnea increasing? Are the physical symptoms worsening? Is the physical examination showing worsening of the involvement of skin, or are there any new nodules seen, or any new nodes seen? Supraclavicular nodes are they involved? So, or is there any back pain, any back bulge? So physical examination. So declining performance status, is the patient more and more restricted to bed, or unable to move around much, or not eating properly? Is there accelerating weight loss, which might indicate a greater liver involvement as well? You have increased alkaline phosphatase, which can come from any of the vital organ involvement. Have abnormal liver function tests, hypercalcemia, which can come from bony involvement, worsening on the PET-CT or other radiology, or increased tumor markers. So what can we do as a generalist? We can strive to maintain adequate nutrition, keep long-term viable venous access, ensure the proper control of other comorbidities. See, the infections, diabetes, hypertension, cardiac function, lung function. There are so many comorbidities which can be independent of the disease and the treatment, or which can be part of the disease and the treatment. So we have to identify and ensure that these are all properly controlled. While doing all that, we also have to ensure the mental well-being of the patient and the family while maintaining realistic expectations. Sometimes just making fun at life in general, talking to them as human beings, talking to them one-to-one, laughing with them makes a difference to them. They are humans. We are also humans, and we treat them as humans first. That makes all the difference, if you ask me. So then comes the follow-up. After the completion of surgery, intravenous therapy, radiation, we normally follow them up 3 monthly for 1 year with all the tests and other things, and then 6 monthly for 4 years, and then annually. For triple negative patients, we follow them up a little more intensively, or as symptoms or problems suggest. And with that, I conclude my talk. Thank you so much.
Our next speaker is Dr. Ekta Vala Chandarana. She is DM Oncology and Director at Medisquare City Hospital. And over to Dr. Ekta Vala, please.
Okay, thank you so much, sir, for inviting me. Should I share my slides,
Yeah.
sir?
Sure.
I hope now it is visible.
Yes.
Okay. So,
Yes,
first of all, thank you, sir, for giving me this wonderful opportunity. So, I am going to discuss today about gynecological cancers and HPV vaccine. So, gynecological cancers, they are the major health concern among women. Breast is the commonest cancer in our country, and it is followed by cervical and ovarian cancers. So among these two cancers contribute to the highest disease burden and clinical workload. Cervical cancer is largely preventable, while ovarian cancer is often diagnosed at advanced stage, and it is called as a silent killer. So our whole session will focus on these two important cancers, and we'll try to discuss about prevention of this cervical cancer. So here are the important types of gynecological cancers. One is cervix, one is ovarian, then it is followed by uterine cancer, and of course less common vulvar and vaginal cancers are also the part of these cancers. So it is one of the commonest. Cervix is the commonest in our country, and unfortunately we see high mortality due to late diagnosis and low screening uptake. If we talk of ovarian cancer, then it is one of the leading cause of gynecological cancer deaths. High mortality is of course because of silent progression and lack of effective screening for this cancer. So, according to the latest Globocan data, Every year we are saving almost around 1,17,000 new cases of cervical cancer. And the painful thing is, out of them, 79,000 women with cervical cancer, they are dying because of cancer. So the mortality rate is more than 50% or more than 60%. And so it is one of the leading causes of cancer-related mortality. So unfortunately, though we do have screening recommendations, screening tests to detect cervical cancer at early stages, in spite of that, these are the painful numbers we are discussing today. And if we talk of ovarian cancer, annual new cases were around 47,000 in 2022, and annual deaths were 33,000. See, out of we see the mortality rates were around 70%. So high mortality was due to late presentation and lack of screening, as we discussed. So first we will discuss everything about cervical cancer, which I think every family physician should know. So basically, it is caused by human papilloma virus. So the persistent viral infection is responsible for the development of cancer. This virus is sexually transmitted, and long latency period allows the scope for prevention. So once you get viruses in your body, then it takes years to develop pre-cancer lesions, and from that it takes of course years to develop cancerous lesions. So we have long latency period. In that period, we can detect cancer at much earlier stages and even in pre-cancerous stages we can detect. So at stage 0 we can detect with the help of screening test. So what are the types of this virus? So we divide it into the low risk and high risk groups. Low risk human papilloma viruses, they are responsible mainly for genital warts, where the high risk HPV virus, they are oncogenic, and among them HPV 16 and 18, they are the responsible for the majority of the cervical cancers. So here we see the natural history. So HPV infection, then persistent, and then it is followed by development of precancerous lesions, that is called as CIN. So from CIN1 it progressed to CIN2 and then 3, and then there will be a progression to invasive cervical cancer over years. So HPV infection usually, as I discussed, it is transmitted sexually. So soon after we get infection, one get infection soon after sexual debut, and we see precancerous lesions in around 20s and 30s, and we see cervical cancers in around age group of 35 to 55 years. So these are the symptoms of cervical cancer: abnormal vaginal bleeding, postcoital bleeding, persistent vaginal discharge, and if it is advanced, then patient may have pelvic pain. So pain is rather not an early symptom, but it is rather a late symptom. If the patient is having pelvic pain, then we can assume that it must be some advanced stage. So any abnormal vaginal bleeding can be cancer unless proven otherwise. So we have to investigate with the various investigations, and we should try to find out the reason for abnormal vaginal bleeding. If one is having postcoital bleeding, then it should not be ignored. If one is having postmenopausal bleeding, then it is the alarming sign, and we should go in detail and in depth. So we have to check always for any abnormality in the cervix, any lesion, any ulcer in the cervix. So the first important thing here is history, and the next important thing here is the speculum examination, even before the sonography or CT or MRI. So based on the symptoms, one can do speculum examination, and if anybody is having the abnormal speculum examination, then they can refer these patients to gynecologist to investigate further. So we luckily we do have screening test available to detect cervix cancer at early stages, and we all know it is Pap test. So Pap smear detects precancerous changes, it detects early stage disease, and regular screening reduces incidence and mortality. So the earlier we find cancer, the better we can fight it. Screening is not just a test, it is a life-saving opportunity. So we can prevent it with vaccination and with the help of Pap smear. Secondary prevention can be done. Both are complementary and not interchangeable. It doesn't mean that you have taken HPV vaccine, then you can skip Pap smear. They both should be the part of routine prevention and screening agenda. So if we see the Pap smear, discuss the Pap smear in detail, then we have different methods. One can use conventional Pap smear, one can use liquid-based cytology, and one can use most advanced HPV DNA. Now the HPV DNA kit is widely available, and with simple spatula, same like earbud type of spatula, we can just rub that spatula around the vagina and cervical lower cervix part, and we can send this to pathologists to detect any abnormal cells and to detect HPV DNA. So any trained nursing staff, they can also do HPV DNA testing with modern technology. So ideal recommendation is to do Pap smear starting from the age of 21 years of age. So any woman above or at the age of 21, Pap test should be done. If one is using conventional Pap test, then it should be repeated every 3 years. If one is using HPV DNA method, then we should repeat Pap test every 5 years. So with the help of Pap test and HPV DNA test, we can see any in situ cancer cells. We can detect at a pre-invasive cancer stage, and if we treat that pre-cancerous lesions, then we can prevent development of cancer among those lesions. So it is very easy. It takes hardly 5 minutes, and I think every 3 years one should spare time for the Pap smear, because it is life-saving. We can detect at stage 0. The mortality increases if we detect cancer at stage 3 and stage 4. The cure rates are very high if we detect at stage 1. If we talk of stage 1, then the cure rates are above 95%. If we detect at stage 2, the cure rates are above 90%, so around 90-92%. But in stage 3, the cure rates drop down to 70% only. It means out of 100, you can save up to 70% patients, and 30% patients, they are going to die if they are detected at stage 3. And if we detect at stage 4, then we cannot cure it. Only 20% patients, they are cured with the modern medicine. So early detection is the only key, and of course one can prevent the development of cancer. So it is very much safe, it is painless, and it takes very less time to perform, and it can be performed at tertiary centers as well. So if we talk of HPV vaccination, then see, as I discussed, cervix is caused by HPV virus. But in Corona era, we have seen the vaccine has done wonderful job. Similarly, this HPV vaccine is not a new thing. It is there with us since last 20 years. But nobody, or rather I can say very less number of people, they are opting it. Majority, they do not know about vaccine. And it is not yet included in our national immunization schedule. But yes, the government last year, they declared that it will be a part of our national immunization system. So there are basically 3 types of vaccine. One is Gardasil 9, which cover 9 variants of HPV virus. The cost is high because it is covering the almost all the important variants. And followed by, we have Cervarix or Cervavac. The one which Bharat Serum is made is Bharat Serum has made, which is Cervavac, and the cost is 2,000. It covers 2 important strain, that is 16 and 18, which are responsible for majority of the cancers. And the third is Gardasil 4, that is quadrivalent vaccine. The cost is around 3 to 4,000. It covers the 4 strain of HPV virus. So, if we talk of efficacy, it is highly efficacious. The efficacy is about 95%. It prevents HPV infection if taken in at appropriate age. It prevents cervical precancers and maximum benefit when given before HPV exposure. So, who should take this vaccine and at what age? So, the ideal age is 9 to 14 years. So, if our kids are below 15 years, then they should be given 2 doses at the interval of 6 months, say 0 and 6 months. If the one is more than 15 years of age, then it can be taken up to 26 years of age or before marriage, then the doses are 3, 0, 2 and 6. Suppose if they have not taken till the time of 26, then catch-up vaccination is possible. But with the thing in mind that if the vaccine is taken before the viral exposure, then the efficacy is above 90, above 95%. But once one is sexually active, one is beyond 26 years of age, then the efficacy goes down to 40%. There is no harm of giving vaccine. The recommendation is there to, it can be given up to 40, 42 years of age, but the benefit is less. So ideally, we should take it before 26 years of age. And if we talk of safety profile, the safety is very well established. Majority people, they do not get any side effect. But if there are some side effects, then it can be some local site pain or I have seen some syncops after vaccination, which is usually common with any vaccination. But apart from that, it is highly safe. There is no long-term effect on fertility or any other organ damage is found so far. And more than 3 million people worldwide have taken this vaccine. So it is highly safe. So vaccination does not replace screening. It is very important. Vaccinated women still require pap test and screening remains essential. So I think we have discussed everything about vaccine. We usually do not give HPV vaccine in pregnancy. We should differ while pregnancy, but yes, it can be given in HIV positive patient. It can be given in immunocompromised patients. If one is infected with HPV virus, then also vaccination can be given because it will protect from other strains. If one has one strain, then the vaccine can protect from other strains. So, as I discussed, it will not replace the screening. Screening is also important because the vaccine is not 100% efficacious, and screening is very much important to detect at early stages. So if we talk of ovarian cancer, then it is second major gynecological cancer, often called as the silent killer, and no effective population level screening test is available. Many routine blood checkup, they involve CA-125 tumor marker to detect ovarian cancer at early stages, but yet it is not recommended by any guidelines because it is not that specific and not that sensitive to be used in screening, to be used as screening test. See, majority of the ovarian cancer patients, they have symptoms. Majorly, we see the symptoms as early satiety, abdominal indigestion, pelvic heaviness, or discomfort. So the symptoms are very vague, and that's why majority patients, they are detected at stage 3 and 4, and where some 25% patients only, they are detected at early stages. So as a family physician, we have to be very alert, and we have to be suspicious so that we can. So any symptoms out of this early satiety or indigestion or pelvic discomfort or pain or abdominal distension, if they are for more than 2 to 3 weeks, then one should think of ovarian cancer and should go under direction of investigation like sonography, TVS, CA-125, and further imaging. So the risk factors for the ovarian cancers are early menarche, late menopause, increasing age, and family history. So ovarian cancer is the disease of old age, around 50 and 60, majority of the patients we see, but one is having a positive family history, then they are at risk of ovarian cancer at very early age. We have seen patients at 30s and 40s as well. So the symptoms we discussed, and so once we see the this kind of symptoms, we do sonography, we do CA-125. On sonography, many of the times we see the simple cyst, and if there is a simple cyst, CA-125 is normal, then there are less chance that cyst is cancerous. But if we see the complex cyst with high vascularity, with solid component inside, with high CA-125, then gynec oncologist or gynec oncosurgeon should be involved as soon as possible. We cannot wait and watch this type of suspicious cyst, and because it can be life-threatening. If we talk of other cancers like uterine cancer, the main symptom, the major symptoms is post-menopausal bleeding. So any post-menopausal bleeding should not be ignored. We have to look for uterine cancers. But yes, it is the third most common cancer. We do not have any screening test so far for uterine cancer. If we see vulva, talk of vulva and vagina cancer, they are very uncommon. And yes, they are also caused by this HPV virus. So one vaccine can be protective for cervix cancer, for vulva cancer, vagina cancer. And this vaccine can also prevent from oropharyngeal cancer and penile cancer, anal cancer. So it is not only females or girl child they have to take this vaccine, but vaccine is for all, irrespective of gender, because it can prevent warts, it can prevent oral cancer, oropharyngeal cancer, it can prevent penile and anal cancers. So the key take-home message, if we talk of cervical cancer, it is the only cancer where we know the exact cause, where we have vaccine, where we can detect it at early stage with the pap smear. So if a woman dies of cervical cancer today, then it is not a system failure. It is a system failure, but it is not a science failure. And that's it. So focused prevention and early detection can significantly reduce morbidity and mortality. So the cancer day, 4th February, the more we talk of cancer, the more we talk of the screening test and symptoms, the more we can spread the message, we can spread the awareness, and this is how we can improve our painful numbers of mortality. We can prevent cancers, and we can improve mortality numbers. Thank you so much.